All right, it's connected now. Shit, man. Sorry, hi, namaskar, adab, sat sri akal. So there was some technical glitches because of which we were not able to, I was not able to enter the live stream. So then I saw that there was a little mistake. So I'm sorry for that. So please join. Thank you so much. Hi everyone. Namaskar, adab, sat sri akal. So let's go forwards with the explanations which we were doing. एंड हम बातचीत कर रहे थे कार्डियोलॉजी की एंड हम डायरेक्ट कार्डियोलॉजी के ऊपर बात करेंगे विदाउट वेस्टिंग एनी फर्दर टाइम दिस वुड बी अ कार्डियोलॉजी रिव्यू राइट एंड वी विल बी रिव्यूइंग फर्दर एस्पेक्ट्स विच वाज नॉट डन टिल लास्ट टाइम ओके हमारा ये सारा चीज़ें हो गया था और हम बातचीत करेंगे आज एक नए सिरे से अबाउट द aortic regurgitation, aortic insufficiency. So let's talk about aortic regurgitation today. And all right. So hi, thank you. All right. So aortic regurgitation or aortic insufficiency. Here we are talking about this. I'll just open this so that I can see your comment. So you can comment and ask me any questions which you have on this particular topic or any other topic cardiology related which you have. Okay. And so sorry for the delay. 4-6 peoples are there. So right now I've been what I'm trying to do is I'd say from today we will be doing revisions and most important not wasting any time. Okay, let's go forward. So what is aortic regurgitation? It is the aortic valve insufficiency. So basic here is whenever the left ventricle which has a aortic valve and there is a left atrium which has a mitral valve. So here this particular mitral valve and this particular aortic valve which is there. Okay, so aortic valve is leaking back into the ventricle. So this is the aortic regurgitation. Okay, so when this particular thing happen, because this is valve, the main function of this valve is to prevent the black flow of blood into the left ventricle. But this is not being done either because there is any kind of change in the structure of the valve. In aortic valve, as we know, there is three particular cusps, and three cusps normally seal the particular door properly so that the blood does not leak. So blood leak नहीं होता है normally, मगर aortic regurgitation में हो क्या रहा है, many times sometimes what can happen कि there is only two particular leaflets. So ये क्या हो गया, bicuspid aortic valve. ये bicuspid aortic valve हो गया. और क्या हो गया, कभी कभार aortic valve में कोई valve जो है it does not really close, it is just stuck somewhere. So what happens, it's stuck and it does not close properly. So this particular whole window is open for the blood to leak back. So a lot of these combinations can happen because of various diseases to cause a leakage into the aortic valve. Aortic valve causes back leakage into the ventricles. Okay, so यहाँ पर what is happening, जितना बड़ा लीकेज जितना बड़ा उतना ज़्यादा ब्लड वापस आएगा. तो then this particular thing is aortic regurgitation. ठीक है. Now if there is a significant fraction of blood ejected into the aorta comes back into this, ऐसे केस में आपका कार्डियक आउटपुट भी कम हो सकता है. बिकॉज व्हाट इज कार्डियक आउटपुट इज जितना भी आपके वेंट्रिकल से एक बीट में आपका ब्लड पंप हुआ, एक मिनट में एक बीट में कितना पंप होता है उसको कहते हैं स्ट्रोक वॉल्यूम. तो स्ट्रोक वॉल्यूम, ओके, एंड दिस इनटू द हार्ट रेट पर मिनट इज इक्वल टू द कार्डियक आउटपुट. तो इफ द स्ट्रोक वॉल्यूम आधा, मान लीजिए स्ट्रोक वॉल्यूम आपका 70 ml है और 70 ml में से बिकॉज ऑफ दिस लीकेज व्हेन द हार्ट ट्राइज टू रिलैक्स बिकॉज दिस डोर इज नॉट fully stuck तो वापस आ गया. In that case what will happen, there will be some blood leakage back. So 70 ml में से say 20 ml leaks back, so only 50 ml is there, so ultimately cardiac output will decrease. Okay, this is what it is. And because of this, what will happen? There will be increase in preload. Increase in preload means because of this leakage, जो next time आपके ventricle में blood volumes है, end diastolic volume which should have been 120, now it has this 20 ml which is regurgitated back, so it will be 120 plus 20 which is 140. So 140 ml यहाँ रह गया, so ये क्या करेगा? प्रीलोड बढ़ा देगा. तो ये क्या कर रहा है? प्रीलोड बढ़ा दिया इसने. So this means there is increase in preload in the case of aortic regurgitation, और ये हो रहा है because of the blood regurgitating back into the ventricles. This will increase the stroke volume in the next contraction. Understand here, in the first contraction, stroke volume is reduced. The second contraction, because the end diastolic volume is basically increased, therefore the stroke volume increases. And therefore this although it is not necessarily an effective stroke volume in the sense कि यहाँ पर stroke volume percentage wise बढ़ जाएगा, because according to Frank Starling's law, जितना ज़्यादा blood volume भरेगा, the stretch on the ventricles will increase, and that will increase the force of contraction, right? We know that. So if instead of 120, 140 ml of end diastolic volume is there, ventricles are stretching more, the force of contraction should increase. So instead of initial 70 ml, which was in 120 case, maybe here it pushes out 90 ml. So maybe it pushes out 90 ml. So technically stroke volume increases. So this is what we are talking about here, right? So this particular mechanism actually helps to maintain the relative normal systolic pressure. नहीं तो क्या हो जाएगा? नहीं तो अगर वो 50-50 चलेगा जो पीछे दिखाया था, so there will be drop in the blood pressure. But here what happens? Stroke volume increases, and this particular mechanism maintains the systolic blood pressure. Okay, then diastolic blood pressure can be substantially reduced because of the backward flow. वो क्या रहा है? Backward flow आ रहा है. And how that is because अब की बार stroke volume 90 है. 90 में से भी मान लो 20 ml वापस जा रहा है. 20 ml वापस जा रहा है. अब ये 20 ml वापस जा रहा है और बचा कितना? 90 में से ये गया तो the 140 minus 90, so वापस उसमें एंड सिस्टोलिक वॉल्यूम हमारा बच गया 50 ml. तो एंड सिस्टोलिक वॉल्यूम में 50 प्लस पीछे से आ गया 120, टोटल आ गया 120 प्लस 20, यानी वापस ये हो गया, तो सेट हो गया अलग ही. बिकॉज ऑफ द रिगर्जिटेशन, the end systolic volume and diastolic volume, cardiac output, all three values will change. End diastolic volume will increase, stroke volume will increase, cardiac output will increase, and blood pressure will increase, and regurgitation will increase, and the pressure, intraventricular pressure will increase. But the diastolic blood pressure will reduce. Why? Because during the diastole, normally the valve is closed. When the valve is closed, what really happens is कि there is no place for that pressure to go away. Because of that, अब because pressure ब्लड को वापस पंप कर दे रहा है, सम प्रेशर इज एक्चुअली लीकिंग, इसकी वजह से बैकवर्ड फ्लो की वजह से डायस्टोलिक ब्लड प्रेशर इज रिड्यूस्ड, एंड देयरफॉर देयर इज वाइडनिंग ऑफ पल्स प्रेशर. ओके, so there is a wide pulse pressure which is commonly seen in aortic regurgitation, and because the total systolic blood pressure is increased, it will be forceful bounding pulse. It is called water hammer pulse. Water hammer pulse को ये समझ लिया हमने. So this is how the hyperdynamic circulation, aortic diastolic murmur of regurgitation is coming, because obviously regurgitation will happen when the ventricle are relaxing, and it's a diastolic murmur. So that's what it is. Okay, then What about systole? This one. In this case, ये तो चलो हो गया, ये तो हमने देख लिया. This is also done. So what are the causes of aortic regurgitation? So one, if there is any kind of connective tissue disorder which leads to any issues in the valve structure, something which can be structurally Marfan syndrome or Ehlers-Danlos syndrome, which is there congenitally, valvular issues. Sometimes the valve can be infected because of some infection or inflammatory processes like endocarditis or syphilitic aortitis. So these things can affect the aortic valve and can lead to regurgitation and opening in the valve. So they can destroy the structure, and the valve can have multiple abnormalities. Now, what is mitral stenosis? So we know that mitral valve is a bicuspid valve. It's like a fish माउथ जैसा ओपनिंग दिखती है हमको उसकी बढ़िया से ऐसे, और फिर उसके बाद में so something like that. So it's a bicuspid valve which opens from the left atrium into the left ventricle, right? So we have seen that. And here agar stenosis hai, that means in diastole blood comes through the bicuspid valve, the mitral valve, into the left ventricle. Agar yahan par stenosis hai, meaning it's not opening completely, say it's opening only half, so what will happen? There will be, the blood will come with more force and less amount of blood will be able to come here. Okay, so if less amount of blood, meaning there will be some residual blood extra which is remaining in the left atrium. So in diastole, mitral valve opens and provides negligible resistance in normal cases, negligible resistance, but in mitral it becomes stenotic owing to many other cases, maybe abnormal structure, maybe other things. Okay, maybe calcifications, maybe thickened the AML or PML leaflets, they can get thickened. As a result, what happens? There is a large diastolic pressure gradient between the left atrium and left ventricle. So what do you mean by diastolic pressure gradient? Meaning during the diastole, during the ventricular diastole, there is a negative pressure here which is generated, and here technically the negative pressure which should be there, it should also be here, because after contraction, after atriolar contraction, एक बार यहाँ से contract हो गया इसका, इसके diastole के part में, तो यहाँ पर क्या होगा? एक तो यहाँ पे pressure gradient है, यहाँ पे negative है, और यहाँ पर increase हो गया pressure because of the remnant blood which is coming or staying back. So there is increased left atrial pressure seen in the mitral stenosis. So because of the increased left atrial pressure, and there is negative, because less blood is coming here, so there will be negative left uh, ventricular pressure. So there will be a increased gap here, जिसको हम बोलते हैं ये issue. ठीक है? So this is how the large diastolic pressure gradient बोल रहे हैं. हाँ, स्पष्ट बता. ठीक है? तो हाँ 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 हाँ, ठीक है, बोल ना. हाँ, 6 बजे के बाद बात करूँगा. ओके, तो इसमें क्या करना है? एक तो लार्ज डायस्टोलिक प्रेशर हो गया. नाउ वी आर टॉकिंग अबाउट द रेजिस्टेंस ऑफ ब्लड फ्लो अक्रॉस द माइट्रल valve obviously has increased, and there is adequate ventricular filling can only occur if there is pathologically elevated atrial filling pressure. So because slowly left atrial pressure will increase, ठीक है, सो धीरे धीरे यहाँ से प्रेशर आएगा और एडिक्वेट फीलिंग होने की कोशिश करेगा. टू सम एक्सटेंट योर हार्ट कैन अडेप्ट इन say mild mitral stenosis, mild or maybe a partially grade mild 2 plus or moderate mitral stenosis, your heart adapts and you don't really feel any significant symptoms. So after a while your heart will stop adapting, and there will, because of the high left atrial pressure, this will cause hydrostatic pressure in the pulmonary veins, which are putting blood into the left atrium. है ना? So because of this, capillary pressure will be elevated inside the lungs, and there will be the increased net transduction, transudation, which will there. Transudation की वजह से pulmonary institution में edema होगा. This will cause pulmonary edema. Fluid accumulation will be there. Because of this, कुछ amount तक तो pulmonary lymphatics can adapt, because pulmonary edema हो रहा है. That significant edema होने के बाद your patient will fall into a pulmonary this CHF, congestive heart failure, or whatever you call it, heart failure, lung, that will be there. लेकिन कुछ हद तक initial stage में जब कम पानी होगा लंग में, then your pulmonary lymphatics can actually reabsorb the fluid to prevent the pulmonary edema. But after a while, the pulmonary edema will set in, and after a while, if the left atrial pressure exceeds 30 to 40, the compensatory capacity of lymphatics is overwhelmed and fluid begins to accumulate in the lung, and ultimately patient will land into a congestive heart failure. Congestion is at the mitral valve, and the reason might be rheumatic fever. Pathology. The most common reason of mitral stenosis, where there is the symptoms of, agar CHF hoga, the symptoms of dyspnea will be there, exercise intolerance, dyspnea on exertion, initially class 2, then there will be increase to class 3, then class 4, patient gets admitted, and sometimes the whole structure of the heart actually changes, and these kind of issues, they take a long period of time, maybe like 10-20 years after the acute rheumatic fever stage. So this particular fluid accumulation, when we talk about fluid accumulation, actually causes the symptom of mitral stenosis, is because of the mitral stenosis, which we already said, dyspnea and reduced exercise capacity. Okay, now the degree, agar degree of stenosis is severe, तो उस case में there is a option of repair, where we do either commissurotomy. That means if the mitral valve is not opening properly, if it is like closed and then opens a little bit, then you can actually do a commissurotomy, or you can just insert a balloon, and balloon valvoplasty can be done percutaneously, or you can actually replace the entire mitral valve, which can be necessary to prevent the fatal progression of disease. Now, what is the fatal progression of disease? Fatal progression means, if at all, what happens slowly, if because of this particular left side of the heart, if we say something like this, yes, okay, if this is the heart, this is the mitral valve, which is not really opening, it's normal, should be like this, and it's basically stenosis, only half of this is open. So here the left atrial pressure will increase, and slowly, first there will be left atriolar dilation, right? Then you can have, because of the left atrial dilation, what will happen? The mitral annulus will stretch. Mitral annulus will stretch, and this particular uh, stenosis, meaning it's not closing properly, and in this case, the regurgitation will be added. Various degree of mitral regurgitations will be added because of the stretching of the annulus, and mitral valve will be stretched so that it's not completely closed. Right here, we are talking about it's not opening properly. Now we will be saying that it's also not closing properly. So it's basically stuck because of that, and mitral regurgitation will be added. So intraventricular pressure will also be increasing, and this will basically go into the lungs. वहाँ पर lung का pressure बढ़ेगा, intrapleural pressure, so pulmonary pressures will increase, will in turn increase the pressure of the right atrium, and right ventricle first, and then the right atrium. Okay, so slowly the entire heart will adapt. It will increase in size, the volume, then that because of that, over the period of years, a patient will repeatedly fall into a cardiac failure, right? So this is how it is. What is happening? left atrial, here the mitral valve, and this is the aortic valve. Here the first thing which happens is left atrial hypertrophy plus dilation. Both things happen. Then there is, if over the period of time mitral valve regurgitation develops, then there will be a LVH, or else no, right? Stenotic mitral valve opening will, there will be a opening snap and diastolic rumble also. Okay, so because during the diastole, the force of the blood coming inside will be much more, so this will actually increase the S3 sound, and this will lead to the diastolic rumble. Okay, then this LA can push on the esophagus also. LA can push on the esophagus, and patient can have esophageal dysphagia, or this can be one issue which can be seen. And because of the mitral stenosis, less amount of blood will come down into the ventricles. The volume will be less, so therefore the cardiac output reduces. Okay, and RVH will also happen if PH, pulmonary hypertension, develops. So this is the schematic representation which I've already explained. RVH. LVH can happen only if there is mitral regurgitation. If there is no mitral regurgitation, no LVH will happen. Okay, then there is no LVH will happen. Sit down there. Sit down there. Can you give me some time? I'll be back. Okay? Mama will help you. Go. All right. Sorry. All right. So we are talking about the mitral regurgitation. So let's talk about mitral regurgitation, insufficiency. So here the same thing is happening, similar thing. This is the particular valve. Here we have the bicuspid valve. Here we have the mitral valve, and here regurgitation, in the sense it is not closing properly. Okay, it is not closing properly. So if it is not closing, then what will happen? There will be regurgitation of in early systole during the ventricular contraction. What happens basically? Let's try to understand. Early systole mein there is ventricular contraction, and in isovolumetric contraction, when both the valves are closed, nothing basically happens. And here left ventricular pressure increases because of the isovolumic contraction, and then the aortic valve opens. Okay, but if there is a uh, in mitral regurgitation, the valve does not form a good seal. So because there is no good seal in the isovolumetric contraction, what will happen? The blood will end up flowing back into the LA during the isovolumetric contraction. So blood goes back because there is no good seal allowing blood flow. Therefore, obviously there will be increased left atrial pressure. है ना? So obviously the left atrium will enlarge. LA will be enlarged. LA hypertrophy can also happen. Okay? Then here, because left LA can also enlarge and left ventricle can also enlarge, because after the next cycle, during the next cycle, the volume which is coming back into the left ventricle will be more, because obviously left ventricle is putting back some volume here. Normally that particular volume which is going here of blood, say 10 ml, 20 ml, should have been gone into the aorta, and it would have come back after circulating through the systemic circulation into the right atrium. But now it is directly coming back into the additional volume is coming back into the left ventricle through the additional volume of left atrium. You're getting it? So here that is. So if there is more reflux in the systole, this is the main problem here. Reflux in the systole. So this mitral valve in the systole will cause regurgitation, and this left atrium will get enlarged. Left ventricle will get hypertrophied because of the more fluid coming back here, and slowly hypertrophied left ventricle, more fluid will increase the systemic blood pressure, and this can in turn increase the venous return, and can increase return. This return will lead to ventricular hypertrophy, right ventricular hypertrophy also. And obviously, if left atrial pressure is increasing, it will again put pressure into the pulmonary vessels, leading to pulmonary hypertension, just like the last time. Pulmonary hypertension होगा, फिर ये वापस राइट हार्ट फेलियर होगा, राइट आर्टेरियल प्रेशर होगा, यहाँ पर भी, यहाँ से भी प्रेशर बढ़ रहा है, वहाँ से भी प्रेशर बढ़ रहा है, दोनों तरफ से इश्यू आएगा. Always remember, it's a very complicated picture, and always एक ही चीज नहीं होती है. Always in the heart there are multiple things going on, and multiple things are causing issues together. So here we can see high velocity flow throughout the systole. So that's why there is a diastolic murmur, which we can say pan diastolic murmur. What are the symptoms of mitral regurgitation? So यहाँ पर क्या होगा, with there will be reduced forward flow, cardiac output initially. And because why? Because one, the right heart failure is going to happen. Second, LA is dilated, so it will retain more amount of blood also. Okay, and because elevated left atrial pressures is there, elevated left ventricular volume overload is there, and there is additional preload which is there imposed on the ventricle as well as the atrium. Therefore, there will be the imposed on ventricle by the additional regurgitation. This can cause forward flow, reduced forward flow cardiac output. Where symptom will depend upon the temporal course of this issue. What does this mean? Temporal course क्या होता है? See, acute setting में, if there is a rupture of the mitral papillary muscle in some kind of mitral regurgitation, there will be acute and severe case of mitral regurgitation. If there is a acute severe mitral regurgitation, immediately significantly your left atrial pressure will increase significantly, significant pulmonary hypertension will happen, and significant pulmonary edema will happen. So pulmonary edema is significant, can even lead to fatal pulmonary edema. Patient will collapse in minutes, you can say. Patient कुछ ही देर में फट pulmonary edema हो जाता है. तो क्योंकि एकदम से myocardial infarction हुआ. That myocardial infarction, for example, maybe is involving the left anterior LAD territory. say LAD territory में वहां पर, because mitral valve जो है, mitral valve के उसमें there are papillary muscles here. तो यहाँ से क्या हो गया, papillary muscle टूट गए. तो ये भैया जो leaflet है, it's just swinging around here, and it's like ऊपर नीचे, and whole blood is going back and forth. So acute rupture of papillary muscle, acute severe myocardial infarction, acute severe MR is a serious complication. The patient will need very rapid management. What kind of rapid management? Because acute pulmonary edema हो सकता है, patient can go into pulmonary edema. So patient needs that diuresis चाहिए उसको, fluid नहीं देना है, fluid restriction देना है, blood pressure, forward blood pressure should be there. If the blood pressure drops, right, if the urine output drops, if you give more fluids, if the patient is lying down, venous return increases, right? If all these things can actually put more pressure onto the left atrium, more pulmonary hypertension, more pulmonary edema. You have to make sure that patient is in a reclined position, make sure that patient is given oxygen, or if needed BiPAP support to actually reduce the pulmonary edema which is already set in. make sure that the urine output is rather more, so you give diuretics. So you make sure that the intake is less, right? I know I'm not writing everything, but you can understand by what I'm saying. All right, so here this is what is important, and in this case, in MR, acute MR, pulmonary lymphatics are not able to compensate for this. But yes, in chronic settings, in chronic ischemic cardiomyopathy, if it's a gradual process, that means if it is a mild MR, then it goes to slowly goes after some years to moderate MR, and slowly after so years to severe MR. Then remodeling of the heart can happen. Remodeling adjustments can happen. Left atrium has the time to enlarge, become more compliant with the regurgitation. And pulmonary lymphatics have the time to augment their function, to reabsorb and prevent pulmonary edema. All these things play a big role. So जितना acute MR होगा उतना severe patient. Although pulmonary complications are less likely in chronic settings, but increasingly larger fractions of the left ventricular stroke volume are diverted into the low pressure aorta after a period, and therefore this will decrease the stroke volume and cardiac output. This will slowly over the period of time lead to fatigue, weakness, dyspnea on exertion. Okay, so there is dyspnea, not angina. Angina on exertion is not related to this, but obviously there can be patient who has concurrent coronary artery disease. So that patient can also have angina on exertion, because ultimately it's an ischemic cardiomyopathy. Na? Somewhere or the other, the initial pathology was coronary artery disease, right? Which led to, say, some damage to the base of the papillary muscles, which is controlling the mitral valve. And because the base of papillary muscles were weakened, the mitral valve could not close properly, could not seal, therefore there is a leakage. Okay, so very nice simple phenomena happening here. What is mitral regurgitation? Okay, note, mitral regurgitation can also have because of mitral valve prolapse. So prolapse is nothing but whenever there is a say if there is a valve is going overboard. Normally the valve is something like this. This. So when it basically opens, it's like this. When it's closed, it's like this. So in leakage, in prolapse, it becomes like this. So this is the leak area which is leaking. Okay, this is the annulus, the annulus, the annulus. Okay, so leakage is something like this. So if the prolapse is there, in which the leaflet basically billows into the left atrium ventricle, so it basically LA के अंदर जब भी पानी घूम जाएगी ऐसे LA के अंदर जाएगी. This is the prolapse. Mostly this will go. This will go prolapse. This is the prolapse. Normally it should be like this. Going back is prolapse. Both can also prolapse. This is also possible. Okay, one can prolapse, both can prolapse. दोनों ऐसे ऐसे हिल सकती है. It can become like a fan. Can happen, but it's okay. What happens here is the mitral lever goes back and classically gives a mid stroke click on the auscultation. Mid stroke click can be there, and mitral regurgitation is the most common form of valvular problem which is there, and very usually it is very symptomatic. If you see very clearly, a trace amount of mitral regurgitation will be seen in almost everybody, 90% of the people, even young patients, even young children. If you actually look for it, trace amount of leakages will happen, right? Okay, now this pathophysiology of murmurs. So should we go into this, or should we cover this in the next chapter next time? So tell me, I need a comment in the live chat. If there are people, 6 people are there. If you want me to go on with the pathophysiology today, You tell me, then I'll teach half an hour more. Or we'll meet next time. All right. Come on. All right, let's teach for some time. So, what is the pathophysiology of murmur? So, murmur is basically the turbulence of the blood flowing through small holes, small openings, or leaking through small openings and creating sounds. Okay, anywhere it is normal, laminar flow is silent, and turbulent flow causes sounds, murmurs, or brutes. So, yes, Suraj is saying yes, very nice. So, there are types of murmurs, and in order to understand and remember the types of murmurs, you have to remember what is happening inside the heart and at what phase the murmur will happen. It's a simple factor, and there are these four types of murmurs which you need to remember: aortic valve murmurs, mitral valve murmurs. These are the two valves murmurs, and tricuspid valve murmurs are also important. But why? Because these are the more important ones from the exam point of view. Aortic, three particular. So whenever we are talking about a murmur, you can remember this particular image where there are these particular this heart, and there are four chambers. Aortic stenosis murmur is basically coming from the left when there is a aortic valve stenosis, meaning कब होगा aortic valve के through जब there is a systole whenever the left ventricle is trying to contract and push the blood through the aortic valve, there will be increased force in the initial, because it's a stenosis. Stenosis means it's not opening properly. You need more force to open, just like when you need more force to open a door which is stuck. So you put on more force and there is a sound tuck and it opens. So that's what happens here whenever there is a systole. So throughout the systole, because it's going to be stuck, it's stenosis, there will be increased velocity of blood going through the left ventricle into the aorta, and because of that stuck, normally it should open like this properly. Now it's opening like this. So a lot of gush of blood is going, और वो gush narrowing valve के वजह से it's causing systolic murmur. Just remember right now that this aortic stenosis will lead to systolic murmur. And obviously, after the systole, the heart relaxes. There will be diastole. And during diastole, the normally blood will try to go back. And normally, this particular valve, which is like this, will close and seal. But in regurgitation, it's not able to close. So it's basically leaving some gap. Okay. So in both places, there is a gap. Okay, in both places there is a gap. Here the gap is in the forward flow, here the gap is in the reverse flow. Okay, in the reverse flow, if there is a gap, there will be regurgitation. Here there will be stenosis. So in the regurgitation process, it's going to happen in the diastole. So it's going to happen in the diastole, and it's going to happen because in the early diastole, so there will be turbulent flow back into the ventricle from the high pressure aorta, and here it decreases in intensity throughout the diastole. Why does it decrease in intensity throughout the diastole? Because initially there is high pressure in aorta. High pressure in the aorta, and as soon as it goes down right here, intensity of pressure in aorta will go down, and the pressure through bit by which, and plus because it's diastole, remember the blood is coming in from this part of atrium also. So if the blood is coming in from the atrium also and ventricles are filling up, that means the negative pressure in the ventricle is becoming positive, and the aortic pressure, which was high positive, is also getting low. So the gradient of pressure becomes less. Therefore, throughout the diastole, the intensity of murmur becomes less. This is the reason why in diastole the intensity of murmur is less, and in systole, because the contractile force of contraction of ventricle is constant throughout, right? There is a systolic, complete systolic murmur. Now, what about mitral stenosis? In mitral stenosis, same thing happens. Here there is a valve, and here there is another valve. In mitral stenosis, what is happening? Normally, the valve is supposed to open like this, and the blood is going to come down. Here, the stenosis is like this, so there is a small opening for the blood to come down. So, because of the stenosis, one during when will be the blood coming down? Obviously, in diastole. When there is a diastole and left एट्रियम से ब्लड आएगा नीचे, तो डायस्टोल के टाइम पे माइट्रल स्टेनोसिस का मरमर आएगा. दिस इज इट इज नाउ बिकॉज नॉर्मली लेफ्ट वेंट्रिकल का प्रेशर जो होता है वो अपने आप में बहुत हाई होता है, और लेफ्ट एट्रियल का प्रेशर जो है वो उतना हाई नहीं होता एज मच एज अयोटा. इसलिए अयोटिक रिगर्जिटेशन का जो फोर्स था वो बहुत ज़्यादा था, तो वहाँ का प्रेशर ज़्यादा हाई साउंड था, हाई पिच था. यहाँ पे क्या हो रहा है, टर्बुलेंट फ्लो है लेकिन इतना ज़्यादा प्रेशर ग्रेडियंट नहीं बना पा रहे, तो इसलिए डायस्टोल में जो मरमर है वो इतना ज़्यादा स्ट्रॉन्ग नहीं है. तो माइट्रल स्टेनोसिस will lead to a diastolic murmur first of all, but not very strong. Now when we cause regurgitation, तो इसका उल्टा हो रहा है. Regurgitation में maybe there is a prolapse, उसके वजह से regurgitation हो रहा है. So during regurgitation it will happen in systole. So in systole there will be, throughout the systole, blood is pumped up into the left atrium also. So throughout the systole there will be systolic murmur. So this is the only thing which you need to understand this diagram and what is happening in the heart. Systole होगा कि diastole होगा, early systole होगा कि early diastole होगा, or wherever there is a contraction of ventricle involved, that means in the mitral regurgitation and aortic stenosis, there will be a systolic murmur, and this will be throughout. यहाँ पे भी throughout systole है, यहाँ पे भी throughout systole है, right? And whenever there is other parts involved, because other part यानी कि जो एट्रियम से नीचे जा रहे हैं, वो वाला भी पूरा सेम टू सेम इंटेंसिटी थ्रू आउट डायस्टोल नहीं आएगा उतना अच्छे से. समझ रहे हो? तो दिस पर्टिकुलर डायस्टोलिक मर्मर, सिस्टोलिक मर्मर इज देयर. व्हाट अबाउट दिस? मायोकार्डियल ऑक्सीजन सप्लाई एंड डिमांड बहुत कम में हो गया, बहुत कम स्लाइड थी मर्मर की. सो वी विल एक्सप्लेन दिस मर्मर अगेन. I think I should cover, this was a review, so it was in short. So we will explain the murmur again, and next time और अच्छे से डिटेल में मर्मर को लेंगे, बट कॉन्सेप्ट तो समझ में आया होगा. Let's understand how the blood flows into the myocardium. Myocardial blood flow. Let's talk about that. Myocardial oxygen supply is directly related to the rate of blood flow within the coronary arteries, obviously, and is dependent upon the length of diastole, यानी कि कितना लंबा diastole है, and the diastolic perfusion pressure. So what does this word say? The length of diastole. It means if the heart rate increases, the length of diastole decreases. This means the coronary blood flow will decrease. So heart rate is not good for, higher heart rate is not good for coronary blood flow. That's why we give beta blockers, and other medication to reduce ivabradines to reduce the heart rate. What about the diastolic blood pressure? Diastolic perfusion pressure. What does that mean? Diastolic perfusion pressure means वेंट्रिकल से लेफ्ट वेंट्रिकल से aorta में हमने पुश किया. क्या पुश किया? The end diastolic volume is pushed into the aortic, the stroke volume. Stroke volume is pushed inside the aorta, and there is a particular aortic systolic blood pressure is generated. And this aortic systolic blood pressure के साथ में यहाँ पर जब हम डायस्टोल जाते हैं तो there is a diastolic blood pressure which is here in this particular because of the closure of सीलिंग ऑफ aortic valve, ब्लड वापस नहीं आ पाता है, यहाँ पर एक डायस्टोलिक ब्लड प्रेशर आता है. दिस डायस्टोलिक ब्लड प्रेशर जितना ज़्यादा होगा उतना ज़्यादा प्रेशर यहाँ से जनरेट होगा. So it depends upon the diastolic perfusion pressure, all called a diastolic blood pressure at the base of the aortic root. ठीक है? And then it depends upon the vascular resistance of the coronary artery. What does this mean? It means if there is a blockage into the coronary blood vessel, if there is a coronary blood vessel which has plaques, this will increase the vascular resistance. 50% blockage is there. If there is another plaque, which is like 70% blockage is there. If there are another blood vessel which is like 99% blocked, or there can be two particular plaques which is this is 99%, this is 90%. So this will increase the systemic, this will increase the vascular resistance of coronary artery. So blood flow will depend upon atherosclerotic plaques, vascular resistance. One more way why vascular resistance can increase if there is a myocardial bridge. What is that? It means when the coronary artery is actually flowing under a muscle tissue. So muscle tissue is heart muscle tissue is over the coronary artery. Over the coronary artery. What will happen? Whenever there is a high forceful contraction, for that particular contraction time, this particular blood vessel will be closed. This is called as a myocardial bridge. Okay. So if this will increase the vascular resistance. This is a temporary, episodic, on systole vascular resistance. This is a constant vascular resistance, atherosclerosis. So vascular resistance is there, diastolic perfusion pressure is there, length of diastole is there. तीन particular चीजें हैं. Length of diastole. Let's talk about this. Increase extravascular pressure generated during the left ventricular systolic pressure compresses the coronary vessels. Now what is this? Because in systole, length of diastole, increase extravascular pressure generated during left ventricular systole. So during systole, normally your coronary blood vessels are compressed. So very little or no myocardial blood flow happens during systole. That's why even if myocardial bridge is there, it cuts off a blood vessel. It doesn't actually put a very big, significant resistance, but there is still some resistance. So because of this, left ventricular perfusion is largely depending on the length of the time spent in diastole. And this time is inversely proportional to the heart rate. Like I said, heart rate ज़्यादा होगा तो ये ज़्यादा होगा. So diastole, right-sided coronary blood flow, left-sided coronary blood flow. Now why we are talking about this? Right-sided coronary blood flow means to the RV does not have so much of pressure. Intravascular pressure which is generated during the left ventricular systolic वेसल्स के अंदर का जो प्रेशर है उसके वजह से बंद हो जाती है खून की नस. ये चीज़ सिर्फ लेफ्ट वेंट्रिकल में होगी, राइट में नहीं होगी. इसलिए राइट वेंट्रिकुलर में ये देखो सिस्टोल के दौरान लेफ्ट साइडेड कोरोनरी ब्लड फ्लो इन ड्यूरिंग सिस्टोल इज लेस, but in left-sided coronary, right-sided coronary blood flow is more. You see, comparison. And during diastole, left-sided coronary blood flow is much more, but right-sided coronary blood flow is not so much more, it is less rather. Okay? And then again during systole, the same thing happens. So this is an important pattern which you need to understand. There are certain things which we talk about. This is the ventricular blood flow. Anyways, we'll talk about that in later videos because वो सारा clinical part हो गया. In contrast, the right ventricle receives most blood when it is flowing during systole. Okay, this is what we need to understand. Because extravascular compressive forces during systole are much weaker in the right ventricle than in the left ventricle. Therefore, the ventricular blood flow is largely dependent upon the spine step. Right ventricular blood flow is depending upon the time spent in diastole. Right ventricular blood is largely independent on that, and left ventricle is dependent on the diastole. What is diastolic perfusion pressure? Driving force of coronary blood flow, the diastolic perfusion pressure, मतलब उस aortic base में कितना प्रेशर है कि वो coronary blood flow के अंदर जाए. So it's the diastolic pressure within the proximal aorta, right? It decreases in condition that decreases the diastolic pressure within the aorta, like aortic regurgitation. If there is a regurgitation, pressure decreases. If there is blood pressure is low, systolic pressure decreases. So this will result in reduced myocardial oxygen supply. Simple fact जो हमने समझाया था. तो क्लिनिकली एक पेशेंट का बीपी कम है, हाइपोटेंशन है, आफ्टर एमआई what happens? The diastolic perfusion pressure may be insignificant to make adequate coronary blood flow, resulting in coronary myocardial ischemia, and this will compromise the cardiac function and cause decreased cardiac output. Further decreases the diastolic pressure. तो vicious cycle शुरू हो जाता है. और थोड़ी देर में टाइम इज मनी. क्यों बोलते हैं 1 घंटे का गोल्डन पीरियड, 6 घंटे के अंदर रिपेयर कर दो, 12-24 घंटे का कोई फायदा नहीं. So there are some norms there because damage will happen very quickly, right? And to increase this perfusion pressure, intra-aortic balloon pump can be inserted. Intra-aortic balloon pump, IABP, can be inserted into the distal aorta. What does that do? Distal aorta में यहाँ पे उन्होंने ऐसे डाल के बलून डाल दिया. ये बलून क्या करता है? whenever there is a systole, during systole, एक basically sorry during diastole this particular inflates. जैसे ये inflate होगा diastole में, it will push some amount of blood back, so it will increase the diastolic pressure in the perfusion pressure in the base of the aorta. So because of this aortic pump, intra-aortic blood pump, coronary blood flow will increase. So intra-aortic balloon pump is therefore used sometimes in patient with very low heart function, very low ejection fraction, very low blood pressure, in cases where we need to do angioplasties or when we need to do bypass surgeries, TABG. So AIBP can improve the diastolic coronary blood flow, which can in turn improve the cardiac function, which can in turn increase the cardiac output, because that is important for the patient to survive. Or else, if there is no blood pressure, within a few hours the kidneys will shut down, the brain will shut down, everything will shut down. There is no use of opening the heart blockages or no use of reviving the heart after that, right? So this deflates, this bump deflates during systole, so that during deflation the vacuum effect, deflation say there is a vacuum effect which augments, which pulls the blood from here, so there is a augments the cardiac output also. So IABP has dual effects, vacuum effect, pump effect. What is coronary vascular resistance? We talked about this. This particular vascular resistance, coronary vessel, is governed by the radius. So if the radius is reduced by a plaque, or the radius is reduced, right? Causes greater resistance, reduced flow. So even though if it is externally compressed, even if it is just externally compressed, something is compressing this particular vessel. Say some kind of tumor is there, some kind of pressure is there, something is compressing the external. This will increase the vascular resistance. है ना? So external compression can be because of systole, heart. Heart, it left ventricle में because of the left ventricular coronary blood flow is reduced during systole because of this particular external compression. During the systole, the heart vessels, they contract so much that there is external pressure on the ventricle, on the vessels. And during diastole, the vessels open and perfuse. This is very much true about the left anterior descending and left circumflex iliac artery, left side arteries. Not true about the right anterior, right coronary artery, RCA. We just saw. And aside from the extravascular compressive forces, there are some local production of various vasoactive substances, metabolic active substances, which are active in cardiac tissue, which are major determinant of coronary blood vessel diameter, hence the coronary vessel resistance and coronary blood flow, which include adenosine, hydrogen, and potassium. Adenosine, hydrogen, and potassium. Atherosclerotic narrowing of coronary blood vessels will increase the coronary vascular resistance. Adenosine, hydrogen, potassium can be vasoactive substances leading to vasodilation or contraction. Atrial oxygen content का क्या रोल है? Atrial बोला था. Arterial oxygen content all right. So arterial oxygen content primarily depends upon the oxygen carrying capacity of the blood, right? Depends upon the oxygen carrying capacity of the blood and determined by the एक तो उसमें कितना हीमोग्लोबिन है, नंबर टू योर लंग्स का गैसेस एक्सचेंज कैपेसिटी कैसा है, efficiency of your lungs and the number of hemoglobin molecules. Normally arterial oxygen content is a constant and the body tries to maintain it. Okay, and therefore if it does not really regulate the myocardial oxygen supply, but in case of severe anemia, reduced hemoglobin, however, because of the decreased arterial oxygen content, this can compromise the oxygen delivery to the myocardium, leading to myocardial ischemia. This can lead to a false positive 3MT test. False positive TMT test in severe anemia. Then, what is the myocardial oxygen demand? So obviously, if there is reduced hemoglobin due to anemia, there will be a level at which, after which, the myocardial oxygen demand will not be met by the available amount of oxygen, by the available amount of hemoglobin. Right? थोड़ा सा hemoglobin कम होने पे एकदम TMT पॉजिटिव हो जाएगा, ऐसा नहीं है. There has to be some determinants of oxygen demand of the heart. So obviously this will be different in different circumstances. If there is more heart rate, demand is more. If there is more afterload, demand is more. If there is more preload, demand is more. Demand of oxygen. If there is more force of contraction, demand is more. So if the most important is heart rate. Whenever the heart rate increases, proportionally more times this spent in systole, and therefore cardiac workload increases, therefore myocardial oxygen demand increases, therefore additionally, because less and less time is spent in diastole, this will reduce the coronary blood flow, as well as the oxygen demand supply simultaneously is compromised. This sets stage for supply demand mismatch, something called as supply demand mismatch. Supply of blood with high oxygen level and demand of that blood to the myocardial muscles. Then second thing which affects the oxygen demand is the myocardial wall tension. If there is an increase in wall tension, which can happen if there is increased preload, which I just said a little bit back, because of more blood is coming into volume overload, kidney dysfunction, these kind of things, preload, or then there can be increased contractility or increased afterload. All these things will increase wall tension. Afterload means blood pressure. This all will result in increased myocardial oxygen demand. So the targets of reducing the myocardial oxygen demand in case of coronary artery disease or in case of anemia this is the most important factor. If a patient आपके पास है जिनको coronary artery disease है, you want the blood pressure, the heart rate, the preload, the afterload, the contractility be less, be controlled. In case of anemia, on one hand you will try to increase the hemoglobin concentration, on the other hand you make sure that the heart rate, the blood pressure, the preload, the afterload, everything is also controlled, so that myocardial oxygen demand is not mismatched, or else whatever the disease, whatever coronary artery disease will be there, this will be symptomatically augmented. The third part is contractility. So myocardium in a positive ionotropic state ejects a greater stroke volume, and therefore and when there is a normal or negative ionotropic state, वो तो पता ही है हमको, ज़्यादा contractility, ज़्यादा stroke volume. If the stroke volume is increased, therefore myocardial oxygen demand is decreased. We know that. Now, talking about angina, pathophysiology of myocardial adaptations. So our time is बहुत ज़्यादा नहीं है, but I'll talk about this angina part next time. Okay, because I need to. There is another class now. There is another class at 4:30 p.m. This class is on the Unacademy app. Please go down and press the link on Unacademy and follow me there. Unacademy app पे आ जाओ, ठीक है? Please do that. Thank you so much. Stay connected. Stay healthy. See you next time.